As you know, targeted therapies, including erlotinib and crizotinib and others, can work quite well in patients with mutations. After a period of time, sometimes a few months, sometimes many years, eventually cancer will start to grow back. And at that time, there are several different options that one can take, and I think that that's an important point to talk with a patient about how they are tolerating the treatment and about how they're feeling. And that really will help guide the appropriate management. And so the options that I see are in patients who have one or even maybe two or a few sites of disease that are growing in the setting of other disease that's very stable or doing very well and responding still to the targeted therapy. I think we have some data now that shows us clearly that just treating those few, 1, 2, maybe 3 sites with another treatment, such as sometimes surgery, but usually more like radiation, and then continuing the targeted therapy is a very reasonable strategy, and it's one that I use in patients, again, who are overall feeling well and doing well with their targeted therapy, but have one or a few places that the cancer seems to be growing even with the treatment. So that is a very good strategy that I use when it's a few places that seem to be growing and otherwise the disease is stable. In patients where more than just a few places are growing and cancer seems to be growing in places that you can't just consider radiation in them because of the multiple places that things are progressing, there are a few options that one can consider, and again, things depend on how patients feel and how quickly things seem to be moving along. So when patients feel well and the cancer seems to be just slowly growing, much slower than it seemed to be growing before they started the targeted therapy, I think that treatment is still working, even though it may not be working as well as it was a few months ago or a few years ago. And I like to continue just the targeted agent if I can. And that's because usually by this point patients are feeling quite well on it and the side effects have all been well managed. And very often we can get months or even years more of treatment with just that one targeted treatment without having to add other treatments or switch to other therapies. So if it seems that the cancer is still growing slow enough that we have some good control with the one agent, I will continue that alone. When cancer seems to be growing faster than is ideal or patients are becoming more symptomatic, that's when I think we really need to think about other options. And that usually means either chemotherapy or treatment on a clinical trial of other targeted agents that may be effective once the cancer has acquired resistance to the initial agent. And I think those are two both very good treatment strategies, either a trial or chemotherapy. I think still an open question for which we have some data is whether to continue the targeted therapy along with chemotherapy. We know that for erlotinib, it's safe to combine chemotherapy and the erlotinib, and so that is a strategy that I will often pursue, is continuing the targeted therapy while I add chemotherapy. With other targeted therapies, we don't have as much data. So for crizotinib plus chemotherapy, we don't have data yet whether that's safe, although there are studies that are now looking at that question. So for patients who have acquired resistance to crizotinib, I would either consider switching to chemotherapy if I felt they needed a new treatment, or really trying to find a trial that is looking at other targeted therapies for ALK-rearranged lung cancer that may have better control at the point of resistance than crizotinib does at that point.